Yes.
We'll start from this. We're going to basically follow the path of the blood as it would go through the heart. The superior and inferior vena cava are going to collect the blood as it returns from the body. We're going to bring it here to the first chamber of the heart, which is the right atrium. The heart has 4 chambers in it. We're actually only going to walk through 3 of the chambers.
Okay.
You always hear the heart described as a pump. There's actually 2 completely separate pumps working side by side. The right side of the heart that we're standing in deals exclusively with unoxygenated blood. The left side of the heart deals exclusively with oxygenated blood. So as blood comes to the heart, it's going to fill this chamber. This is the right atrium. This right atrium is going to fill up. When it does, it's going to contract and it's going to push the blood through this valve into the second chamber of the heart, which is the right ventricle.
Is there a name for this valve?
This is a tricuspid valve.
Tricuspid valve. Okay.
What they're showing here is basically just a thrombus. For better, lack of a better term, it's a blood clot. Basically, a clot like this is at some point it can break off.
Yeah, tragic.
And if it's in a vein, it's going to come back to the right side of the heart. It basically has nowhere to go but out to the lungs. And it can end up causing a pulmonary embolism. True medical emergency. What they're showing behind you here is a patch of endocarditis. Almost all of it is bacterial in origin. If it is, it's going to be more on this valve than on the heart wall itself. The primary bacteria that causes that is in your mouth. So if you have a history of any sort of heart valve damage, rheumatic fever, a lot of other conditions, before you go to the dentist to get dental work done, they'll normally give you a dose of antibiotics. They're going to kill that off because if they accidentally cut your gums, that bacteria now has access to your bloodstream. And once it gets in your bloodstream, it's going to go to the heart, and it's going to stick on one of these valves and start growing. It's called vegetation. At that point, it's very difficult to get rid of it. It's usually 6 weeks of IV antibiotics to get rid of that once it's growing on the heart valve. In a normal heart, this septal wall would be solid all the way to the back, but 1, we've got to have a way to walk through the exhibit, and 2, if you've ever heard of a baby that was born with a hole in the heart, we're normally talking about a ventricular septal defect. The problem with VSD is that it allows unoxygenated blood from the right side of the heart to mix with the oxygenated on the left. It gets pumped out to the body, but it's not doing any good because it's not carrying any oxygen. Usually the first clinical signs of that, we call them a blue baby. They're cyanotic. And that's usually the first clue to the doctors and the staff that are delivering the baby that, hey, there may be a problem with the baby's heart. Wow. So once this chamber fills with blood, it's going to contract. It shuts this valve, diverts the blood through the pulmonary valve, and sends it up to the lungs to pick up oxygen.
So is that every pump it does that? Wow.
Right. So it's going to send the blood up to the lungs to pick up oxygen. Once the blood picks up oxygen, it's going to come back to the left side of the heart. Blood would come back to the left atrium, which is behind this wall. Just like on the other side, that atrium will contract. It pushes the blood through this valve. This is the mitral valve. So the blood comes through this valve and it fills the 4th chamber of the heart that we're standing in. This is the left ventricle. This is pretty much the workhorse chamber of the heart, in that it's got to contract with enough force, shut this mitral valve, divert the blood through the aortic valve, and pump it out to your body to start the whole process over again. When you get your blood pressure taken, the top number on your blood pressure is basically a measurement of how much force this chamber is contracting with and pushing the blood through the arteries. From the time you're born to you're about 70 years old, your heart's going to beat between 2.5 and 3 billion times. It's a pretty amazing pump. And unlike skeletal muscle, which when you sit down or you sleep, you're watching television, that muscle gets to relax and take a break. Cardiac muscle never gets to do that. So because of that fact, blood supply to the heart muscle itself is absolutely critical. So if you end up pulling it around to the outside here, if you end up with a blockage in one of these coronary arteries, whatever piece of heart muscle that artery was feeding is going to die. It's called a myocardial infarction or heart attack. Previously, the only thing they could do to restore blood flow was they would strip a vein out of your leg or out of your arm, and they would sew one end of that piece of vein into the aorta, sew the other end into this coronary artery, and bypass the blockage. So when you hear someone talk about they had a double, a triple, or quadruple bypass, that's what they're talking about. What they can do now in a lot of cases, it's not a magic bullet that makes bypass surgeries obsolete. Those are still done every day. But in a lot of cases, if the cardiologist says you're a candidate for it, they can put a stent in to restore blood flow. with one of those, instead of basically being split from here to here in some cases, they'll make a small 1-inch incision on the inside of your thigh, sometimes on the wrist, and they're accessing an artery. And under fluoroscopy, or basically watching on a TV camera or monitor, they will thread a guide wire up through into the coronary artery into the middle of that blockage. On the end of that guide wire, if you want to get a close up of this picture here, on the end of the guide wire, there's a little tiny balloon, and there's a mesh basket surrounding that balloon, which is the stent. Once they put it in place in the middle of the blockage, they will inflate the balloon. Not only does it dilate the vessel, but it opens up that stent and it locks in place. Once it's open, they'll deflate the balloon, pull the wire out, and the stent stays behind, actually holding the blockage open. None of this is foolproof. We still have problems with some of these. Because you're talking about a foreign body, your body can treat it as a foreign object. And one of the things it's going to try and do is create scar tissue. To coat this and isolate, protect the body from it. Well, whether it's blockage from calcification or scar tissue, if you end up closing off the artery, you're back to where you started from. So a lot of these stents, especially the smaller ones now, they'll even coat it with a medicine that prevents scar tissue from forming, so that by the time that medicine wears off of the stent, it's pretty much grown into the wall or the intima or the lining of that coronary artery. Yeah, it's fantastic.
So impressive.
Right.
I mean, who even thinks of these things? It's really impressive.
Talking to some of the cardiologists around the country, depending on where the blockage is, which coronary artery is blocked, instead of doing the full sternal incision, they can make a couple of incisions between the ribs. They can actually detach an artery from the back of the chest wall and sew it onto the heart and do a bypass while the heart's still beating. So it is amazing the progress.
Amazing the science that we have come to. So
Absolutely.
fortunate. We're fortunate to live in a world where the science is so, progressive.
Well, that pretty much concludes the tour.
Great. Thank you so much.
Sure.
I really appreciate it.
Absolutely.
Thank you.